on Facebook.
Live and on Facebook.
Good evening, everyone, all 3 or 4 of you out there. This is the first time I've ever done anything live and on Facebook, so if I fumble a lot, well, I hope you're entertained. My name is Michael Moore. I'm a doctor here in Denver, and February is Fibroid Awareness Month. Next to me is my lovely wife, Donis, who has worked with me for most of the last 37 years as the research arm of the Advanced Women's Health Institute. The Advanced Women's Health Institute is focused on women's care for fibroids and endometriosis as areas of excellence. We have won awards for some of the work we've done, and so we would like to make folks out there aware of what the state of the art is for fibroid care. And so if you know somebody with fibroids, if you know somebody who's got really heavy periods or really painful periods, let them know. We're going to be on every Tuesday through February to spend a couple of hours talking about fibroid care, talking about things that can be done for fibroid care, and letting women know about the things we do, and hopefully you'd share this to let other women know. We're going to share some patient stories. In a week or so, we will have an actual live patient coming on and telling her story. We'll have a few patients. We just kind of want to get our feet wet with how to do this, and there hopefully won't be too much dead air time. But yeah, it's definitely different being on this side as opposed to watching things. And so we had some slides prepared that were supposed to show up there. On the other hand, it's just we're not all that technologically savvy. So here's kind of our slides. I think we can probably get a little closer to look at options for fibroids. Yeah, we can. So as we focus in on this, I'm going to switch to the next slide so that everyone will have a better idea about fibroids. And you can think of fibroids as 3 different kinds. The submucosal fibroid is the one that's here in the middle. And the reason it's called a submucosal fibroid is because it's growing from the muscle wall into the uterine cavity, and the uterine cavity is lined by a mucus-secreting glandular structure called the uterine lining. The endometrium is the technical name. Fibroid tumors are tumors of the uterine muscle. The uterus is a big muscle. Through that, the cavity is inside the uterus. The cervix holds the uterus, holds the pregnancy in place. The pregnancy grows inside the cavity, and then when you get to that term of pregnancy and all that stuff kicks in, then you start into labor. So the muscle starts to contract and push out the fibroid, or not the fibroids. Hello. Push out the baby. For reasons we don't fully understand, women tend to have a mutation of a uterine muscle cell, and it turns into a fibroid tumor. So that muscle tumor begins to grow, and we don't really know why it happens. We don't know why it happens to 18-year-old women, or why it happens to 47-year-old women, although it's much more common to occur in the 40s. And it's just one of those mysteries, but they occur a lot, and they create a lot of problems, a lot of bleeding problems. And so when you get the submucosal fibroid, the one that's growing from the muscle wall and is arising very near to the cavity, as it grows, it starts to expand the cavity. When you look inside with a scope, you can see these big blood vessels at the surface of the fibroids. I have a video from a long time ago where I was looking in with a scope, and the blood was just streaming out the blood vessel. So you can get an appreciation for why this woman had incredibly heavy menstrual periods. The interesting thing about the submucosal fibroids is they tend to occur, and you go into the doctor, the uterus isn't enlarged. A lot of women hear the line, "Oh, it's just your age." common way to kind of, say maybe that's why. But the problem is just a physical exam doesn't tell us if the woman has a small fibroid inside, simply because the uterus has to be large to get an idea that maybe there's fibroids there. So ultrasound is a very important diagnostic tool we use to identify fibroids. And I've had many a patient come to see me because they were having heavy periods. They went in, they had a physical, they were told it's just your age, it's one of those things. But then we put the ultrasound on, and sure enough, there's the explanation of the submucosal fibroid. Other fibroids are what we call either intramural, that's the one over here on this side, and an intramural fibroid means that it's growing kind of in between the outer and the inner surfaces of the muscle. And then there's the subserosal fibroid, which is growing closer, starts closer to the surface of the uterus. So the subserosal fibroids can be felt as a bump on the uterus. They're the ones that generally got to get pretty large in order for a woman to have problems. So these are the kind that a woman says, I rolled over in bed one night and there was something in there, and I pushed down on my tummy and there was this big hard thing in there. And that's, we call it a mass. And what happens is that fibroid that's further away from the cavity, less likely to cause bleeding, it can grow for a long time, so they generally get quite large at 7, 8, 10 centimeters. 10 centimeters is the size of a newborn baby's head, and we take out a lot of 10 centimeter fibroids around here. So the women look pregnant, they're going to the bathroom frequently, they have a lot of pressure, and so that mass effect is what makes women uncomfortable. So the intramural fibroids, the ones that arise kind of in between, well, as they get bigger, they start to distort the cavity. As they get bigger, they cause those bulk symptoms. So, that's the kind that's fairly easy to find when you do the physical exam because the uterus is enlarged. And typically, as doctors talk about exams and fibroids, we talk about weeks of pregnancy size. 16 weeks is 4-month pregnancy size. 20 weeks is 5-month pregnancy size. But everybody understands the fruit scale. And so, lemons and limes, if they're near the cavity, are going to cause a problem, but they may not cause an appreciable increase in the size of the uterus. But when you get to oranges and grapefruits, those start to, definitely feel larger on exam, so you're feeling a mass. And so that's when you kind of start to think fibroids. And so woman comes in, she's having heavier bleeding, the cramps are getting worse. Usually we think of fibroids. But again, ultrasound is really important to diagnose exactly what's going on. And I'd like to think that the quality of ultrasound at our institute is of the highest standard. And the reason I say that is we're invited to participate in FDA studies, which require that we have to have some pretty sophisticated equipment and some pretty good knowledge skills in order to be able to help women who are entering into clinical research. And clinical research is a great way to help women who have fibroids. And we're going to talk about that in just a moment. But fibroids are incredibly common. That the lifetime incidence of fibroids in Asian, Hispanic, and Caucasian women is 70%. So it's almost certain a woman is going to get a fibroid by the time she gets to menopause. Some fibroids aren't symptomatic, though, and don't require anything, and then other fibroids cause a problem. And if you're of African heritage, the chances of fibroids are even worse. African American women have the highest incidence, 80% lifetime incidence. The average age of hysterectomy is younger for women, African American women, than for Asian, Hispanic, Caucasian women. And the age towards myomectomy is younger. Myomectomy is where you take the fibroid out, not a hysterectomy where you remove the uterus.
and we'll talk about the different kinds of hysterectomies that there are. This is a slide on a breakdown of why women have hysterectomies. And so this pie chart shows that fibroids are the most common reason for hysterectomies. And about 1/3 of hysterectomies are done for fibroid tumors. Now it also shows that 20% of hysterectomies, I'm just going to turn it around real quick, are for what's called dysfunctional bleeding. And dysfunctional bleeding is heavy periods, heavy and irregular periods. And again, it's just a phrase that we use, but dysfunctional bleeding is oftentimes caused by fibroids. And again, remember, if the woman doesn't have an ultrasound, and an ultrasound isn't a requirement to do hysterectomy, it's just simply a choice of the doctor. And we'll get into, not all doctors are really there to take care of your fibroids. They don't have the training, which is a little why we're doing this. But you know, if you just do an exam, you find out on the path report a few days after the hysterectomy the woman had a fibroid, or you kind of figure out why you're doing the hysterectomy the woman has a fibroid. Other reasons for doing hysterectomy, well, you know, if it's chronic pelvic pain, sometimes hysterectomy is the only choice. Endometriosis and adenomyosis causes of painful periods, heavier periods, and so there are other reasons for hysterectomy. And so, but if you look at half of hysterectomies, they're done for fibroids and abnormal bleeding problems. And if you look at adenomyosis as a component of hysterectomy, adenomyosis is a different condition. Adeno meaning gland, myo meaning muscle. Glandular tissue growing into the muscle wall of the uterus. And it's clumped with endometriosis because endometriosis is glandular tissue that looks like the uterine lining outside the uterus, as opposed to glandular tissue which looks like the uterine lining in the muscle wall of the uterus. We kind of classify them as part of the same disease spectrum. We don't have really any idea why women get them. But, you know, adenomyosis is a common cause of heavier periods, more painful periods. I've seen a number of women who come to the office with you know, big uteruses, told they had fibroids. We do the ultrasound. We don't really find fibroids. The fibroids we have are out of proportion for the size of the uterus. And we start to see then funny echoes in the wall of the uterus. We see cystic structures in the wall of the uterus. And all of a sudden we're starting to figure out this is a woman who has adenomyosis. So really the most important part of taking care of the problem is accurate diagnosis. And without accurate diagnosis, everything else isn't necessarily going to follow the logic that is necessary. And so we spend a lot of our time initially taking a very detailed history, then doing a very thorough exam, and I mean an ultrasound exam. And that's where the heart of trying to figure out what's going on comes in, is looking with ultrasound. And then from there, with knowing what the problem is it a fibroid that's close to the cavity? Is it is it adenomyosis? Is it physiologic? And you know, it's very interesting. Over the years, every month, someone will come in with a radiology report or a report from a doctor's office, and they'll tell us they have fibroids. And sometimes they'll even have drawings of their fibroids on the photocopy that they bring in. And then suddenly, as we do the ultrasound, either we don't find the fibroids, or we do find the fibroids. And if we do find the fibroids, we go a step further, we characterize them. And the simple nomenclature, submucosal, intramural, subserosal, is a way to you know, kind of classify fibroids in 3 ways. But then when they're so big that they're pushing in on the cavity and they're creating a mass, we call them transmural, because by then they're so big that you can't really tell the difference between the outside and the inside. The fibroid just kind of dominates the scene. So somebody came up with a classification system from type 0 to type 7. Now, unfortunately, I don't have a slide for that, but I can bring it back in a little while and we can talk a little bit more about that. But those different types help us to understand a little bit more about what role they play, and the closer those fibroids are to the cavity, the more likely they're going to be creating bleeding problems. But even fibroids that aren't totally close may very well interfere with the normal function of the uterus and create bleeding problems. And then it's a matter of, okay, if you don't have fibroids, if it's physiologic, what do we do for that? If you do have fibroids, what do we do? And it's not instant surgery, but medical management for fibroids is something that, yes, it works. It's generally not going to put off the inevitable. Inevitably, something surgical will need to be done. But more importantly, it's those women who come in being told they have fibroids, being told they need a hysterectomy, and then we don't find fibroids. That's where it's like a great pleasure to then talk about medical management, because you're saving that woman's surgery. You've identified this is not generally a surgical problem, although there are some things we do for the heavier bleeding without fibroids. But medical management involves generally oral contraceptives, birth control pills, estrogen, progesterone birth control pills primarily. And the reason for estrogen, progesterone birth control pills is they override the ovaries. And it's very necessary to suppress the ovarian stimulation, the natural cycle of ovarian stimulation that women have, because then you can suppress the buildup of the uterine lining, you can control when the period occurs, and generally periods get lighter and less crampy with birth control pills. And birth control pills are not just the pills, there is the birth control pill patch, and then the NuvaRing is a brand name for one that goes inside the vagina. And it's kind of nice because you place it for 21 days, you don't have to take a pill every day. Some women like it, some women don't. But it's really about options and knowing all the options so that it's not just what do I think is best for you. Now, not all women tolerate the birth control pills. A 40-year-old smoking woman is not a good candidate for a birth control pill. Some women will tell you, I took the pill and it made me the Wicked Witch of the West. So, you don't want to be taking a therapy where your family runs and hides as soon as you get home because they're afraid if you're not going to cry for some silly reason, you're going to be yelling at them for no good reason. And so, and the women are distressed by this. To feel out of control by your emotions is, well, don't talk about that for me. I know. But, birth control pills are a common thing. Now, I do see a lot of women coming in taking progesterone or using progesterone cream, and if you give a lot of progesterone, it might help, but it generally isn't as effective. And so we just have to kind of talk about how effective is something too, just because you can use it or something. And I know progesterone cream seems to have a lot of favor in the complementary and alternative medicine world. Yet the scientific data is a bit lacking. And most everything I tell my patients, tell those women who come to see me for consultation, is really based on scientific data. Either it's based on, this is a study that was published in one of the major journals, and here are the results. Here's something that has had multiple studies to support its effectiveness. If it's not based on a medical study, it's based on opinions of experts, people who know a whole lot about it and teach us. And again, it's also based on patient-centered medical treatments, not just saying you are the patient, you're going to love this treatment, here's the treatments, you're a patient, let's talk about these treatments and what would work for you. One of the other things that we use as a hormonal therapy for heavy bleeding are the progestin IUDs. There's a couple of brand names out there, but to quote a few, the Mirena, the Liletta, the Kylena, those are the names for IUDs that contain progesterone. They go inside the uterus, they release that progesterone directly inside the uterus, where it has that effect of reducing the flow. And these progestin IUDs are relatively popular among young women for contraception, A, they're hands-free, B, they reduce the period, kind of like the birth control pills, and these lower progestin IUDs like the Kyleena don't seem to have the same side effects the birth control pills have. So, it's kind of nice if a young woman has had a poor experience with the birth control pills, a little worried about it, and then she comes in a few weeks later going, it's really nice that I'm not feeling crazy on these pills. So, progestin IUDs, but think about it. A 10-centimeter fibroid is going to be sitting on the bladder. The woman's going to the bathroom more frequently. It's got a mass effect. I mean, it definitely is causing problems with the clothing. So putting a progestin IUD in when a woman's got a 10-centimeter IUD doesn't always make the most sense. And that's a lot of times when I kind of challenge a woman to, consider the surgical approach, because if the 10-centimeter fibroid becomes a 12 or 15-centimeter fibroid, it becomes more difficult. So sometimes it's really important just to say, okay, I've got a problem. It's not going to get any better. When is it time to deal with it? And so, that's when we have to make certain decisions. And again, it's one decision you make for a 7-centimeter fibroid, but a 17-centimeter fibroid, much bigger. One of the things that we offer here is a lot of what's called minimally invasive gynecologic surgery. And I was very fortunate to have great mentors and opportunities to go to society meetings in the 1980s and the 1990s and see some of these procedures presented at these society meetings for the very first time. A few of the things that I brought back to Denver in my days in 1987, I went to the American Fertility Society meeting, and they were talking about doing tubal pregnancies through laparoscopes. Now, these aren't fibroids, but it's an example of how things have changed. In the early 1980s, when I was in training, we'd look inside with the scope. If there was a tubal pregnancy, we'd open the woman's abdomen and take the tube out. By 1987, not only were we using a laparoscope now to take care of the ectopic instead of opening the abdomen, and the difference is days of recovery versus weeks of recovery, pain differences. Women who have had open abdominal surgery and had laparoscopy, the two most common phrases I hear from them are night and day and walk in the park. The pain and recovery are like night and day. Laparoscopic surgery recovery is so less painful. It's so much easier. And the recovery is a walk in the park. How many women get up, get dressed, drive to their office and work for 6 hours 4 days after their hysterectomy? This is just amazing, the things I've learned and been able to offer to the women in our community. To have saved houses, to have saved jobs. It's just been a great honor to take care of women and to help them and learn more. But, if the fibroids are small, if there are no fibroids, medical management, it just makes a lot of sense. And, the nice thing about the IUDs, they're good for 5 years. So, that's kind of nice. 45-year-old woman, she has a heavy period and doesn't want to do surgery, doesn't really have a reason to do surgery. An IUD gets her 5 years, and 5 years from then, maybe uterus is still the same. Maybe she can just get another IUD and she's avoided surgery altogether. On the other hand, the woman who walks in with the 16-week size uterus, the 4-month pregnancy size uterus, the big grapefruit, small cantaloupe, not a small structure. And that's the kind that they're not going to really go away. They're not going to get any smaller. And that's the kind of situation where an IUD might not really be the best thing to do. And so, that's when you kind of really have to kind of ask yourself the question, how can I delay this? And it's not always possible. Now, one way we can help women with what I'd call medical management is through FDA studies. And an FDA study, a company wants to bring a product to market, like a medication, and they have to get it FDA approved. And so what they do is they look for research sites, and because we do clinical research here, we are able to offer another option for a woman. And the nice thing about an FDA study is that if you qualify and you are enrolled and you get medication, you can be on this medication for 6 months, 12 months, sometimes 2 years in some studies. So these medications, people are looking at them for future applications. I wouldn't offer any of the studies I offer if I wouldn't offer it to my own family. So these are medications that we need. They're just a step away from being available tomorrow, but you can get them here today. And so what I'm going to do now is I'm going to turn it over to Donis, because I've talked enough for a while. And let's have Donis tell folks about the Primrose study. Take it away, Donis.
Oh, thank you, Dr. Moore. So, my research assistant, Janine, and I are working on 4 different studies. We have 2 for endometriosis and 2 for uterine fibroids. And we're currently...
One of those fibroid studies is on hold right now, so we're really only talking about 1 fibroid study.
So, but it will be coming back in a few months. So if you missed the Primrose study, we'll have another study that's still ongoing. It's the Obs-Eva is a Swedish company that's sponsoring the Primrose study, and you have to go through a screening period of which you have to collect your pads and tampons. And I know that sounds gross, but I always tell women you have to do something with them anyway. You're either wrapping up pads and putting them into the trash, or flushing tampons down the toilet. So instead of flushing or throwing away, you're going to put them into a little small bag and put them into a container and save them for us and label those and bring them back. You do have to qualify by losing at least 80 milliliters of blood in your menstrual period. So I don't have my little cup with me, but like a little medicine cup is all that it takes to actually qualify. Some women say, oh my gosh, I can pass a clot that size in one time going to the bathroom. So we know that they're going to qualify. And anyway, it's not as bad as you think. I've never had anybody not participate in this study because they had to collect those products and bring them in. Now, what we do is we just pack them up and ship them out to a company that has calibrated those particular pads and tampons so that they can evaluate how much blood you have lost in those pads and tampons. So you do have to, but actually that's a plus, because we're going to provide your pads and tampons for you, and
Free products.
The free products. So there you go. You've saved a lot of money on your pads and tampons.
And nice bags to collect them in.
Yes, and we pay you for bringing them back too. So to compensate, not paying you, we are compensating you for your time and travel to return those to our office. And it really only takes less than 15 minutes to probably bring your products in, have us check to make sure you dated all of them. Because if we don't have them labeled correctly, then the company will not do the analysis. So we want to make sure that you've labeled them, put the dates on there, and collected them appropriately without putting tissue and other things in there to contaminate the collection. So anyway, most of the studies do compensate you for your time and your travel. It's not meant to entice someone to be in a study. The enticement is that we can help you with your heavy bleeding and the pain from those fibroids. So, what
So
else
for
should
the
I say?
Promoter study, you have to be between 18 and
51, I
51.
believe, or
Yeah.
older. Actually, you just have to have regular menstrual periods. It's not
That's
so much
important.
of a upper age limit. If you're still having periods every month, and typically they want you to have a period from 21 to 35 or 38 days, depending on the study. So about once a month, you should at least start a period to be considered to have regular menstrual periods.
Have to have fibroids, that's important.
And Dr. Moore will diagnose your fibroids at your screening visit. The first thing we do when you get here for a study is go through the consent form. It's also called patient information or subject information along with the consent. So the biggest part of the consent is information for you so that you understand exactly what's going to be required of you to be in this study. And so we want to make sure that all of your questions are answered, and at any time, if you're not comfortable, you always have the right to withdraw from the study. If you're not comfortable signing that consent the first time you come in, you can take it home, discuss it with family members, girlfriends, whatever, what do you think about this study, and let us know at a later date. We're never going to force anyone to participate that they're not comfortable with being in an FDA supervised study. Let's see, what else? The screening period for this particular study is at least 2 menstrual periods. You also get electronic diaries, your e-diary, and every day you will answer some questions about whether you had bleeding. Once you're in the study, you'll also put in if you took your study drug, what kind of pain medications that you're taking. We also provide the prescriptions, or in some cases the pain medication. They call them your rescue medications. So there's many benefits, and probably the biggest benefit is that you can help yourself, but also down the road, other women, sisters, nieces, granddaughters, because fibroids are not going to go away. They're part of medical problems that women have to endure. So we'd love to have you come in and learn about our study.
Janine, would you like to add anything? Janine's sitting behind the camera. We're going to coax her out here because some of her friends are probably watching. So I'm going to get out of the way. I'm going to let Janine come up. And then you ladies can talk about the study and some things like that. There we go.
Hello, everyone. So we have our the 2 fibroid studies, which Jonas had already explained everything. And coming from my family, no one ever talked about heavy menstrual bleeding, fibroids, the pain that you can have during your period. It was almost like you were just supposed to have it, and it was supposed to be there. So I think this is a really great opportunity to get the word out. If you could spread this video, share it on your page with anyone who has the heavy menstrual bleeding or the fibroids, anything to help the women in our community that doesn't know anything about it. Because being Hispanic, family members just never talked about anything of this sort. So I think it'd be great to share and help other women that are hurting and in pain, that this could be a really great benefit. You can call us at our office. It's 303-321-2255, and we can call and get you scheduled. Call us, we'll get you scheduled, and we'll do your screening visit and find out if you have a fibroid. And like Donna said, it's for 18 to and women and older. So that's what the great. Did you have anything else, Donna?
Oh, I was just gonna say, it's not for someone who's trying to have a baby right now, because we don't want anyone to get pregnant on the study. So you have to agree to use 2 forms of non-hormonal birth control, primarily condoms with spermicide. We also provide those for you too, so that's another plus. We'll save you some money. If you had fibroids and you wanted to have a child, sometimes the fibroids can cause infertility. And if you weren't ready to have your child right now, you could come into the study, shrink those fibroids down, and after you've gone through the washout period from the study medication, would be an excellent time to try to have that baby. So that's another benefit for younger women with fibroids that can't afford a lot of infertility treatments, don't have insurance for it, just don't have the finances. Can also help that way as well. Let's see, what else?
On February 23rd, we're offering ultrasounds for women that you suspect you have heavy menstrual bleeding, you have a fibroid. We are doing that. You could call our office and we can get you scheduled. We have increments of time slots that we do still have a few more openings, and we would like to know if anyone needed an ultrasound, doesn't have the adequate medical care right now. We're offering that for free for this day only from 9 to 12. So once again, you need to call, make sure that you get signed up and get a time slot to be here for that time.
And I had something else I was going to say. Oh, Dr. Moore does his own ultrasounds, so we don't use an ultrasound tech. If you've had a previous ultrasound, it was done by a tech, you probably had questions and the tech said, I'm not able to tell you what I'm seeing, you'll have to discuss it with the doctor. So one benefit is that Dr. Moore does his own ultrasounds, so you have him captive and you can ask questions while he's ultrasounding and not have to wait for the doctor to get the report from the tech and then discuss it with you. So that's one benefit of having the ultrasound done in our office, is that you can ask those questions. He can show you on the screen, there's your fibroid right there. So that's kind of a benefit.
And another, if you're uncomfortable with Dr. Moore being a male, Donis or I can accompany you in the visit. And we also have other staff members here that if we're unavailable, there will be always someone in there with you to discuss anything that you need.
Every patient always has access
Every
to a
patient always
female
has
chaperone
access to
at
a
our
female
office
chaperone.
if she wants it.
If she wants it.
So
That would be another little uncomfortable, if they didn't know that it was available. So yeah, that's great.
We want to make sure everyone knows we're going to give them the most professional care possible.
So, but it's also not required if you prefer not to have us standing in there and you're comfortable with Dr. Moore, you can refuse to have an attendant in the room. We just want to make sure that you're comfortable, is our main point here.
Every Tuesday, we will have a Facebook Live. I know you can share it on your page, get the word out. We would just like for everyone to know that this is available for this weekend. And every Tuesday, if you have questions, we have the Ring Central that you can call in, you can type in on, and or also you can speak to Dr. Moore personally through the computer there if you would like to answer any of your questions and stuff like that. So,
Or you can email questions to
email
info,
questions,
www.info.advancedgyn.com.
It's also on our website, it's on our Facebook. We will also have the PowerPoint slides up next week for more in-depth.
So, and Janine and I are pretty easy to work with. Most of our patients will say, you guys are a great team. We kind of tag team you while one's doing this, the other one's doing something else. And so we try to be conscientious about your time as well and not have you here for hours on end. So try to
So once again, our number is 303-321-2255. If you have any questions now, we're here live at Advanced Women's Health with Dr. Moore's office. And if you just joined us, thank you for joining us this evening. And if you would like to just call in and give us, actually on Ring Central, on Ring Central, or on Facebook, and we can answer your questions live. I want to thank everyone for joining us tonight. Thank you for allowing us to be in your homes right now. And we just want Dr. Moore to come on back and answer any more questions, and we'll make everything open to everyone. Thank you.
Thank you, Janine. You knew I was going to embarrass the heck out of you if at all possible. So, okay. So, you know, the medical management is something that we always try and do for small fibroids, for no fibroids, to treat physiologic causes of bleeding. Again, the most accurate diagnosis is the important thing. You know, I'm very fortunate that I take care of a lot of medical professionals. I mean, it's a real honor, it's a compliment that doctors would come to me when they find out they have fibroids, and nurses. I mean, you know, it's just, you know, an honor that a nurse will walk in my door. I also take care of a lot of other folks, and I do happen to take care of quite a few radiology techs. And one of the most interesting things one of my radiology tech patients told me a number of years ago, and unfortunately it is a reflection of how things are done. In most OB/GYN offices that just do regular OB/GYN, most of the ultrasounds are done by the techs and interpreted by the techs. Now, you know, probably going to get a nasty phone call or two from some doc that says, no, I don't. I didn't say everybody. But there are quite a few. And same thing when you go to a radiology facility. You don't see the radiologist there looking at the ultrasound. And the radiologist, they're looking at pictures. Well, if they look at a picture and there are markers on it, and it says like, you know, markers like this and this, they're going to kind of assume that's a fibroid. So a little bit of it is a limitation of the abilities of the ultrasound technologist. And although the vast majority are good, you're never going to get 100% perfect with everyone. And so, you know, that is the benefit of getting a second opinion, okay? So never hurts to say, okay, I've been told this, maybe I want to kind of find out if there's other options. What would I do if my family member went to the doctor? I'd sure want the doctor to sit down and talk with them about a lot of stuff that would be reasonable medical options. And there usually are more than one reasonable medical option. And sometimes somebody might choose one that another person might not. So it is always very important to discuss all the medical options with the patient. And there are models of physician-patient interaction in the old-fashioned paternalistic model. You know, tell the patient what's good for them because you know more than them. Yeah, that was great 100 years ago when most doctors had more education than most patients. Today I have patients that walk in my door with more degrees than me. They you know a lot. And so, you know, I think it's more important as a physician to sit down with somebody and help them understand the problems and the solutions while keeping in mind their feelings and beliefs. And that kind of interactive model of the physician-patient relationship is how I always try and, you know, take care of my patients. What would I tell my family? What would I tell my friends? That's what I tell my patients. So we've talked a little bit about, you know, hormonal therapy for fibroids. There's actually a non-hormonal therapy out on the market called tranexamic acid. The brand name that was FDA registered was called Lysteta, and now there's a couple of generics out there, so it's a little less expensive. It's not cheap, believe me, but tranexamic acid, we actually were one of the sites that participated in that study. We could tell who was on placebo and who was on medication. And you know, a woman came into the study, she qualified, we put her on the tranexamic acid that she would take for up to 5 days a month with her period. And at the end of the study, the statisticians calculated the average reduction in flow was 40%. So the flow was almost
half as bad as it was before the tranexamic acid. That's why we could tell who was on med and who wasn't, because the ones who were walking in smiling and didn't have a lot of product, we knew they were getting the real McCoy. Every study has to have a placebo group. You can't get by that. That's part of the FDA. So you have to be willing to get a pill that's inert and doesn't have anything. On the other hand, what we also tell every patient is it's purely voluntary. You can quit anytime. If you get into it and you realize, hey, I'm probably on placebo, or I'm not happy with this, well, we don't try and keep you into the study. We just fill out the paperwork to have you exit the study, and we're here to help our patients and try and help make life better for them. We just can't change the fact that there are rules that we have to abide by. But again, it's just a great compliment that the greater community of the United States recognizes Advanced Women's Health Institute as a leader in the field of fibroid care. But tranexamic acid's an option. You can only take it 5 days a month, so you have to kind of watch it. But for a woman who really doesn't tolerate birth control pills, needs something to help them, it works pretty good. We like it. Now, there's some other medications that we haven't talked about, but they're really kind of more for just shrinking fibroids in preparation for surgery. And the brand name a lot of folks will recognize is called Lupron. Lupron is actually what we call a GnRH agonist, meaning it has a like mechanism. So the ovary is controlled by the pituitary gland, which is up in the brain. And the pituitary gland is primed by the hypothalamus. That's an even higher center in the brain that controls the pituitary gland. And as long as the hypothalamus every hour secretes a hormone called GnRH, gonadotropin releasing hormone, then the pituitary gland functions much like the thermostat in the room. If the heat goes down, if the temperature goes down, the thermostat kicks on and heats up the room. When the menstrual period starts and the woman knows she's not pregnant, that FSH from the pituitary gland, the follicle stimulating hormone, starts the egg growing, starts the estrogen increasing towards ovulation. And if you turn off that action, if you inhibit the pituitary gland from making the FSH to stimulate the ovary, the estrogen levels go down, and when estrogen goes down, fibroids shrink. And so we'll put a woman on this medication for a couple of months prior to surgery. And if the fibroids have only grown in the last year or so, they generally shrink quite a bit. Now, if a woman's had a uterus the same size for 15 years, they're not likely to make it shrink. They're also not indicated for long-term use at this point in time. So when we give those medications, it's because that 17 centimeter fibroid's a little too big to do with a scope and small incisions, so we want to get it smaller so we can offer the woman that minimally invasive surgery, so she'll have less pain, she'll have a faster recovery. And so that's why we use that particular medication. And a medication also that just got released called Orilissa is a GnRH antagonist, meaning it instantly opposes the effect. So instead of an initial stimulation of estrogen like Lupron does, and then it suppresses estrogen, this suppresses immediately. And it's a pill, and that's kind of nice. You take it twice a day. Donis and I actually did the Orilissa study. And it's indicated for endometriosis, but it will soon have a fibroid indication because the study just finished, well, actually not just finished, it finished about a year ago, and then the follow-up time. So that will probably be in the next couple of years, there'll be a publication showing that this can be used to shrink fibroids. And it's kind of fun to be on the leading edge of fibroid treatment here. So medications that can help control symptoms for small fibroids, bridge time before getting ready for a surgery, or hold off for surgery for quite a while by participating in an FDA study. So I always talk about medical management first because I really think that's important for a woman to know all of her options. And sometimes it may not be the best option, but I never want anybody to think I didn't think about that first. So let's move on though to surgery for fibroids. And in the 1980s, I learned how to do a procedure called hysteroscopic surgery. I'm going to kind of throw this slide up here, and Thierry's going to move right in on it. Thank you, sir. Thierry is helping us with this. He's behind the scenes. We might drag him up in a while just to say hi. This is a hysteroscope, okay? Hyster is the Latin term for uterus. So anytime you have a scope to look inside the uterus, it's called a hysteroscope. We use a little tiny one for diagnosis. So here in the office, we have one that's 1/8 of an inch in diameter. So to find out what's going on, we look inside, and sure enough, we see the fibroid that's there. Then we go to the hospital and we use the hysteroscope here. I'm sorry, I'm not doing a good job. This is called the wire loop. And so you can see in the picture how we can just use the wire loop to cut the strips off and one strip at a time take care of the fibroid till it's gone. So for those submucosal fibroids, those ones that cause a lot of bleeding because they arise close to the cavity and they're causing a lot of bleeding and the uterus isn't enlarged, this is the best fibroid surgery I can offer because there are no incisions. You go to sleep, we dilate the cervix, we put that operative hysteroscope into the uterus, we find the fibroid, we resect it out, and you go home that day. Now, the typical patient has mild cramping that day and kind of feels pretty washed out from all the anesthetic medications. Most patients tell me they feel worse off from the anesthesia the day after their hysteroscopic myomectomy because they're just had a whole lot of drugs the day before and they're kind of hungover. But they tell me at worst they generally have mild cramping, that's about it. And a lot of patients don't have any cramping. The second day after their hysteroscopic surgery, most patients tell me they feel pretty close to back to normal. And then 2 to 3 days after the hysteroscopic myomectomy, most all patients are back to work. So you have the procedure on a Friday morning. Saturday's not a very happy day. You kind of lay around, take it easy. Sunday, you're ready to go to church. Monday, you're back at work. So it's just such a quick recovery. And so when a woman comes in early and we find these fibroids close to the cavity, then we can offer them the least invasive, least painful way to get rid of them. So it's a really neat procedure. Now, for those women who don't have fibroids, but they have really heavy periods, and we've talked about medical management, and maybe they tried it and it didn't work so well, or 40-year-old woman, she smokes cigarettes, not a great thing to do. Wish we could talk you into quitting. I know how hard it is because nicotine is so addictive. And if you're not going to smoke, those nicotine things, the patches, the gums, all of that, that's better than smoking those cigarettes. So, but she can't stop, she can't take birth control pills, there are limitations. So, but for women who have heavy bleeding and don't have fibroids, we can do the same technology to do what's called endometrial resection ablation. There, we can remove the entire uterine lining. It functions like a hysterectomy in many respects because women stop having their periods. There have been several studies published in the medical literature showing women are just as happy with the endometrial resection ablation as they are with a hysterectomy. But again, 2 to 4 days to get back to normal activities as opposed to 2 to 4 weeks. So anytime we can offer a less invasive, less painful procedure,
we definitely are going to talk about it. Endometrial resection ablation is not offered by very many doctors across the United States because it requires a great deal of learning curve. Many doctors, when they talk about ablation, are talking about these global ablation technologies. The best one is about 50-50, where about half of the women stop having periods, the other half typically have lighter periods. And it's an easy procedure to do. Again, if you're going through a tampon every hour and you can't go very far from the house, or I've had patients tell me I just never left the house for 2 days during my period because it was so heavy, and I could get into a whole lot of heavy bleeding stories. But if you're changing your tampon every 4 to 6 hours, that's going to seem really nice. On the other hand, if you don't even worry about a period, and that seems to have a lot of appeal to a lot of women. And when our fellow comes next summer, we're having a minimally invasive surgery fellow joining us, a young doctor just out of residency who will be learning this kind of stuff, because this is a subspecialty, and so we're going to see more highly trained doctors in the future. So as she is joining us, she's going to be doing a lot of research, and one of the projects that we already have lined out for her is an opinion on, if you're going to have an ablation, would you just as soon stop having periods, or would you rather have the ablation where it's 50-50? I haven't seen that in the medical literature as to what women think. But it's interesting, some of these global ablation technologies don't really work as well, and a couple of them that were FDA approved had a 10% failure rate, meaning you did the procedure and it didn't change your flow at all. So, and ablation is a great technology, yet, what are we holding up here? Oh, it's 6 o'clock. Is this supposed to go on for 2 hours? Or, okay. Right. Hi, you stuck with me for another hour. You turn it off, go to something else. Keep it running and post it on your website, please. Let other women know about it, please. So, ablation, when there are fibroids, it's just simply a Band-Aid. It's not going to last forever. And I would encourage women to, not pay twice for the same thing. And many doctors do ablations when there's fibroids, and I can tell you stories of, medical mismanagement that shouldn't ever happen. But, it's accurate diagnosis, and it's knowing the outcomes. And that's, I think, the important thing is to tell people, here's the outcomes. And, if you know that these are going to fail in a year or two, do you really want to do them? Because, then you're going to pay your copay twice. So I always try and do the best right procedure the first time. And I don't push something just because I can do it and it sounds easy. Because the reality is, you can do it, it sounds easy, but did somebody tell you, yeah, this is going to fail in a couple of years and you're going to do it all over again? I see those ladies. And I think they would have appreciated it if somebody had said something to them to the effect of, yeah, you have 4 fibroids and they're going to grow. Now that being said, I offer a lot of laparoscopic surgery, and we see the woman who comes in with this configuration. She has the big fibroid, that one on the very top, that one. We call that a transmural fibroid because really it's pushing in on the cavity, it's also growing out, and it's the kind that's sitting on her bladder, and so she's getting up twice a night to pee, and she didn't used to. And so she's getting a little sleep deprived, and that's making her a little grumpy. She's also got the one that's the submucosal fibroid that is causing, the heavy bleeding as well. And then she's got these other fibroids here, and we know they're going to get bigger too. So the difference between laparoscopic surgery and open abdominal surgery, this is the incision. A lot of women who've had C-sections recognize this little 6-inch incision across the abdomen. For laparoscopic surgery, we use 4 ports,
It's called the diamond pattern. And 5 millimeters is a fraction of an inch. 25 millimeters is an inch. So to put in a scope with, at the belly button, put the CO2 gas in so that now, think of the balloon blown up versus the balloon not blown up, there's a lot more room. So now that we've got the CO2 gas in, we can put these other ports in down around the panty line, and the ones on the sides are 5 millimeters. To take out fibroids, we have to have a 12 millimeter port. 12.5 millimeters is a half an inch. So add all those up, fourth of an inch, a fourth of an inch, a fourth of an inch, and a half an inch, and you've got a 1 1/4 inch of incisions to do the same surgery that we used to do with the big open abdominal incision. 6 weeks off work, 10 days off work. Part-time in 4 or 5 days. So it's a lot different in terms of pain and recovery. 99+% of hysterectomies and 98.5% of myomectomies can be done that way. If you know somebody who's been told they have to have an open abdominal surgery, highly encourage them to get a second opinion. I haven't opened an abdomen in over a year and probably close to 2 years, and it's because the woman's uterus was above her belly button. It's just not necessary in the vast majority of cases to open an abdomen. Robotic surgery. Robotic surgery is a way to do laparoscopy, but the ports are bigger. And in the classic 5-port technique, not only do you have an extra port, but they're all bigger. You don't have 5 millimeter ports for robotic surgery. So in 2005, the company got the FDA approval and went direct to the public with marketing. And it seemed like it was the latest, greatest thing, and the marketing was superb. Fast forward, in 2010, we started seeing randomized controlled trials published in the medical literature. And in virtually every randomized controlled trial between robotic surgery and the advanced laparoscopic surgery that we offer here, robotic surgery is more painful, bigger incisions. The recovery is longer. The procedures cost more by about $2,000 each, and the outcome is no better. So why would you pay more to do something that gave you the same result that caused you more pain and recovery? So actually, my very well-educated patients, they ask me these days if I do robotic surgery, and they're relieved to find out I don't. Because it's starting to become apparent that, you know, marketing is one thing. You hear it sounds great, but dig down deep inside. What's the data? And that's what you get here, is you get the data. And so if robotic surgery offered something, I would have been doing it a long time ago. I had those opportunities. You know, the thing about robotic surgery that really makes it special is it was developed for battlefield surgery. You know, do the surgery close to the front line, keep the doctor in the back. They do this through the internet, so to speak. And I remember there was a lot of fanfare when they did a surgery in London, and the doctor who did the surgery was in New York. And that's how it could be done. Wouldn't it be great if they had one down in the South Pole or up on the space station, in case, you know, somebody hurt themselves on the space station? Or a number of years ago, some folks may remember the woman that had breast cancer. She couldn't get out of there because she had, you know, it was snowed in. They could have used the robotic platform to do her breast surgery there. So for remote surgery, it would be a great thing. For everyday surgery, it's not a good thing. And it's funny, in one hospital here in Denver, there's more robotic platforms than are in the entire city of London. I mean, in Europe, oh, we have a caller? Or no, this is, thought we had a caller. Okay, so
Laparoscopic surgery for taking fibroids out. This is the concept. We open the uterus, take the fibroid out. I learned to do the laparoscopic myomectomy the exact same way I learned to do the open abdominal myomectomies. So in taking the myomas out, taking the fibroids out, I do the same thing. I make the incision, I take the fibroid out. You know when you've got to the fibroid because it looks different. It's a whiter color, it's